From New Hampshire Public Radio, I'm Laura Canoy, and this is The Exchange live from home. COVID-19 has made many everyday decisions difficult. What to do about activities that for many of us used to be relatively low risk, like going to the grocery store. Now, once normal events have the potential to spread a virus with serious, even deadly consequences. So today in The Exchange live from home, we talk about this new normal and what psychology tells us about how we perceive information about risk affecting the decisions we make. Our guests today are Dr. Lisa Adams, Associate Dean for Global Health at Dartmouth and Director of Dartmouth's Center for Global Health Equity, and David Ropeik, a retired Harvard instructor and author of How Risky Is It Really? Why Our Fears Don't Always Match the Facts. And just a disclaimer, David Ropeik is the uncle of Annie Ropeik, who's a reporter for us here at NHPR. Well, welcome to both of you. It's great to have you. And Dr. Adams, I want to start with you. Our understanding of this disease and the messaging around it have evolved because it was so new. We always hear it called a novel coronavirus because it was new. At first, we were told, Dr. Adams, this is just like a really bad flu. Now, obviously, we know a lot more about this disease. Just remind us what we have learned about this and the many ways it can affect the human body.
Sure. Thank you for having me on the show, Laura. And you're right. This is a challenging situation for us because this is a novel virus, and we're really learning as we're responding. We refer to it as we're building the plane as we're flying it, right? So there were some unexpected features to this virus that make it so much more dangerous than, say, seasonal flu. We know it's more easily transmitted. It's R0, that measure of how many people with disease will infect others around them, is quite a bit higher. It's roughly double for the COVID virus than it is for seasonal flu, and the mortality is also more significant. Conservative estimates place it at about being 6 times more deadly than seasonal flu. So we know each year flu causes millions of cases and tens of thousands of deaths every year, and we know that the COVID numbers are well surpassing that. But really, it's this pre-symptomatic and asymptomatic transmission that is the virus's sneaky advantage and really our curse for this disease. So if only those with frank, overt symptoms could transmit this disease, it would be so much easier to control this pandemic, and we would be in a very different place than where we are today. But the latest data indicate that as many as 40% of cases may be asymptomatic. And on top of that, the viral load may be highest in the earliest days of infection, when people may not even know they have the disease. They may be asymptomatic or pre-symptomatic. So this is why things like the universal guidance on using face coverings and that 6-foot physical distancing exists, not just for those with symptoms, but really for all of us. And I think if we look at other parts of the country, we can see what the rapid spread of this virus looks like. But we have really good evidence for some of these public health measures. And it's really about figuring out how do we convey that information to everyone to ensure that there is really good adherence.
Wow, so 40%, that is a lot. And why is it so important to understand, Dr. Adams, where people get their information, how people get their information? Obviously, that's always important with any health matter, but why is it especially important with this illness?
Yeah. Well, as I said, so much information is coming at us from so many different sources all the time. And so I think for this current pandemic, one of the reasons that it's been so hard to understand what to do and why to understand risk, which I know we're going to talk about even more later, why that's so complicated is because we're having to receive, digest, and adjust to significant amount of information and sometimes, frankly, changing guidelines as we learn more about this virus and its transmission dynamics. And frankly, that can be confusing and overwhelming. I think also can be a natural tendency for individuals sometimes when they start hearing about information and risk profiles to try to find a way to carve out why it doesn't apply to us. I know that there's a lot of us will say, I don't see myself in that category. This doesn't apply to me. And therefore, maybe I don't need to take the appropriate precautions or follow the guidance. That might be inconvenient or difficult to maintain over the long term. So this really is, I think, a defining moment for our population, not just in New Hampshire, but across the country, of how we deal with risk and uncertainty. And I heard one of my Dartmouth colleagues recently refer to risk as uncertainty that matters. So part of it is our response has to be figuring out what matters most to people if we want them to change their behavior.
Well, and that's where David Ropeek comes in, but in terms of assessing risk and so forth. But on this, one last question for you, Dr. Adams. So why is human behavior stemming from these decisions, these risk assessments that we all make, why is that so important this time around? Looking at human behavior and how humans think about these things and make decisions based on these things.
Yeah, well, it's so important because the evidence is clearly emerging that we really need to have everybody on board, everybody following the recommended public health measures that are being put in place. Again, it comes back to that risk of people not knowing they have the disease or that they are capable of transmitting the disease. So it's really important for having universal guidance and having as much universal adherence as we can with the recommendations that are out there. I can tell you that states that have imposed a mask mandate, for example, have seen a 45% reduction in daily COVID cases within 30 days. We know, too, from studies that have been done in hair salons that, sort of before and after masks were implemented, and in our healthcare facilities, right, where universal mask wearing was adopted in March or April, what has happened with transmission and how the masks and other measures that we've been putting in place have been really effective. But it takes everybody to be involved with that. So that's why I think it's really important for us to be able to reach everyone, find a way to reach everyone, to ensure that everyone's doing their part.
Well, those numbers are pretty stark, and it's the Exchange live from home, and we have a live virtual audience watching and listening tonight, and that's great, and we'd love to hear from you. So what do you want to know about decision-making and how to make smart decisions, or to help your family and friends make smart decisions? Also, tell us what's been the hardest aspect of this for you in terms of making the right decisions about what might be risky or not too risky for you and your family. It's been a tough time for everybody, especially as the weather has gotten warm, to just figure out what is okay to do, what is not okay. Submit your questions on the Q&A. We'd really like to hear your stories and your questions. So, David Ropeek, let's bring you into this. You and many others who study risk assessment, decision making have said people are pretty bad at this. How come?
Well, bad is a pejorative word, so I wouldn't use it that way. Or irrational, that's the word that's more commonly used. People are irrational about risk. That also seems judgmental, like I'm smarter than you because I'm rational, ergo you're irrational. So the way I would describe it is, so as a journalist, I've learned about the psychology of risk perception from academics like Paul Slovic and Baruch Fishoff and others. And the way Dr. Slovic puts it is risk is a feeling. In fact, the dictionary definition of risk is the chance of something bad happening. So chance is what all the science is about. The odds, the exposure, the routes of transmission, all the stuff that Dr. Adams was talking about. Bad is a feeling. So in the end, risk perception, like all our perceptions, in fact, is a subjective mix of how many facts we have, which is usually not that many, and how they feel to us. So you got to give risk perception its due cumulatively, because here's three of us for whom risk perception is work because we're still alive and talking, right? So risk perception is a kind of a use all the tools we can to make as much sense of things as we can. Now, all of that having been said, we screw up all the time. And the answer to why is we've evolved a set of instincts for how our cognition works and how we perceive risk specifically that are fast and easy. Our brain learned to cut cognitive corners because it takes more calories to think, and our brain uses more calories than any other part of our body. So as we were evolving, we learned a whole bunch of cognitive shortcuts to come up to jump to conclusions, basically jump to conclusions. And a set of characteristics with risk leads to this a lot. So with COVID, for example, Dr. Adams was talking about this. I was struck by it. When something's new, we don't understand it fully. And when we don't understand it fully, we don't know how to protect ourselves. And that feels like we're driving the car, only our hands aren't on the steering wheel and our eyes are closed. That's what that feels like. In simple terms, that's a lack of control over our life and safety. And up goes our risk alert system, right? So at first, the doctors were saying, wash your hands a lot. Now it's wear the masks a lot. That's uncertainty, right? And of course, that's going to develop over a novel disease, like Dr. Adams was saying. But you see how that uncertainty is just one of many characteristics that we've inherited from our forebearers that help us quickly gauge is something scary or not. And by the way, just a postscript on this, I don't know whether either of you did it. I didn't. But a lot of people went out and bought toilet paper and or, by the way, guns for exactly the same reason of what I'm just talking about. If you don't feel like you have control, you want to do something that gives you that feeling. That's what they both were. It wasn't like, oh my God, I'm going to have the runs, or oh my God, the germ's going to come to my house and I'm going to shoot it. Right? Those were things that
That
made
would be
people
nice,
feel,
actually, if we could.
Yeah,
if it was
right?
that
That'd
easy.
Be another way to, that would be one way to knock it down. Hopefully nobody's in the background. But those are things that gave us a sense of control. That's how this all works. Seems not rational, and it's not in terms of evidence, but it's what we do with what we've inherited to keep ourselves safe.
Well, and to pick up on what you just said, David, and that's so interesting. You mentioned those, those examples of what people did early on and running out and getting pasta and toilet paper and rice and so forth. What's the spectrum you see now, David, in terms of how people are assessing this risk? Because we see all sorts of behaviors, from people going to, crowded beach bars to people never leaving the house.
So let me get back to the word control. We need a sense of control over our lives to feel safe. And when you're told to wear a mask, and when you're told to stay inside, and when you're told you can't come to the office, and when you're told you can't, all of those things trigger a stress in the human animal, we're still mostly an animal, that says, I'm not driving my car anymore. And all of the things that we're seeing in the news about the masks, and I want to go to the bar, and I want to get a tattoo, I want to go to NASCAR, I want to go to bowling, they're like the toilet paper and the guns. I want to manifest control in my life. What's interesting is, at the beginning of our fear of the disease, that trumped the fear of lack of control of our lives. But lock people up for a couple months, and the other fear adds to the dynamic emotional language. So that's now at work. And of course, that's informed too, and New Hampshire is a perfect state example of this, by some people have different moral kind of underpinnings about how much control or not they should have over their lives. But it speaks to the dynamic emotional nature of this and the complex emotional nature of this too.
Again, we've got a live virtual audience tonight on this special program, The Exchange, live from home. And we'd really like to hear your comments. We're all struggling to make these decisions day to day. We're not sure what is risky and what is not. So tell us, what do you want to know about decision making, how to make smart decisions, how to help your loved ones make smart decisions? And tell us what's been the hardest part for you about deciding what's too risky for you and your family, what is worth the risk, and what is not. Again, we'd really like to hear from you, so submit your questions in the Q&A. David, one more question for you about this idea of assessing risk and how we do it. You mentioned the tools that we have to assess risk. What tools do we use typically? I know you've got this whole presentation on not just the way our brain works, but also sort of cultural cues and who we hang out with and so forth. So just give us a little primer there, David, on the tools that we have at our disposal, whether we use them well or not, to assess risk.
So there's one whole suite of tools that are in the science community, right? A hypothesis, and we test it, the process of science, and that tells us how it's transmitted and what it does to various parts of our body. But for you and I, not scientists, we turn to sources of information that we trust. That's a huge one. You alluded to this earlier in the conversation. We don't like to have to look everything up. Our brains are basically lazy, even when we're afraid, right? So we look to one or two sources, generally sources we trust, politically, NHPR, whomever, right? So that's one of the tools. Who do we trust as sources of information? Another tool is, what's my current personal life circumstance? right? So Dr. Adams talks in the population level. That's where the science is done. But here are three people in the conversation and more listening, and all of us have our own unique circumstances. Like, do I have an elderly parent with a pre-existing condition? You know, I've gotten a lot of letters from friends, help me do that. So one of the other criteria is, what is my personal circumstance? And then what happens is we use a whole bunch of cognitive, in the background, subconscious software to interpret a few bits of information from the science and my personal circumstances. And it's got a whole bunch of fancy names. So if I'm 23 and I want to go to the beach and I just worked out and I'm looking good without a t-shirt on, you know, and all of that, because at 23, that's 23, I say it won't happen to me. That's called optimism bias in the literature, right? If I'm 69, as Dave is, right? Although I don't have any underlying conditions, if you do, you're going to use what's called loss aversion. Oh my God, it's going to happen to me. And you're going to see me mask up and down in my basement the whole time while the other person's at the beach. So that's kind of the psychology, the psychological factors that we use really depend on who we are. But what's interesting is, I'll just say this at the end, they're generally true for everybody. So if you're healthy, you're going to be more likely to use optimism bias. And those will be the people you see not wearing the masks. And if you're not healthy or you have somebody who isn't or whatever, you will see those people masked up and hunkered down. And this has been true of the human animal across cultures and time. So it's built into us. We've evolved these things as humans. Our personal circumstances will vary, but the tools underneath that you asked about are a general set of tools that we all have.
That's so interesting. And Dr. Adams, what can you tell us now about these categories that David says we put ourselves in? Because early on, we were told, look, younger folks, you don't really need to worry about this unless you have some underlying health condition. So what's the sort of fact versus feeling when it comes to these categories that people put themselves in to assess their own risk with this disease?
Yeah. Well, I think you said it rightly. We have seen certain people say, this is really not my disease. For many young people, right, they felt that they're not at risk. If they do get this disease, by and large, they are going to have more mild disease. And they think, I'm going to have, a bad cold, and then I'm going to bounce back. And that has led to some concerning behaviors that we've heard about in the news, right? These so-called COVID parties where someone with the disease will, invite friends over who want to get it so that they can all get the disease. They'll get it over with and get their immunity passport or immunity clearance, and then they are saved from having to follow any of the other public health practices.
I heard about that. I'm sorry to interrupt you, Dr. Adams. I just find that unbelievable that someone would voluntarily get this disease, which, maybe you just feel bad for a couple of days, but you could have organ failure. I'm just not really understanding that risk assessment. But go ahead, Dr. Adams.
Well, excuse me for butting in, but they see a benefit of the choice. So risk benefit is part of the emotional characteristic of the choices they make. Wow. They see the benefit. I'm going to go to a party. I'm going to get drunk. I'm going to meet somebody. That outweighs I could have organ failure.
Oh, sure. Go ahead, Dr. Adams.
And I think, and they would love to get it over with, and then feel like they are protected for life. Unfortunately, that's not what happens. So first of all, we have people who have gotten this disease who are young and have not done well, and they don't bounce back. In the age group of 18 to 49, recognizing that's a large age group, but they make up about 25% of the hospitalized COVID patients. And we know that there have been tragic outcomes as well, and that the medical officer at a Texas hospital recently reported, just this week, I believe it was, of a 30-year-old man who allegedly went to a so-called COVID party, was a COVID doubter, and then got sick and actually died after becoming infected. So this is really everyone's disease and everyone's concern. And so I think trying to, dismantle some of the myths around the fact that all young people will do just fine is an important message that we need to be getting out there too.
Well, we, as I said, are here with a live virtual audience. And right now we're asking them to fill out a poll. For us, we want to know, here's the poll, we want to know, what is the biggest factor that you consider when you're deciding whether to change your behavior, whether or not to fly on a plane, to wear a mask indoors, or to visit friends and family. So the options are my own personal research and interpretation of the science, recommendations from public health officials, my doctor's recommendations, what I hear from political leaders or on the news, or what my family and friends are doing. And we'd like you to pick the one that is most important, even though you might use a combination of these options. We'd like you, just for the poll, to pick the one that is the most important. So go ahead and fill out that poll, and we'll get your results in a couple minutes. Right now, though, we are getting questions from our live virtual audience. So Mary writes, I don't personally feel the need to have a COVID-19 test. However, I hear New Hampshire public health officials encouraging everyone to be tested. Glad to do it, Mary says, to benefit the public's health, but I don't get a sense that there is a clear plan in New Hampshire to use such testing. Help me understand what I should do and why. And Mary, thank you for writing. And I've heard this from a lot of people, Dr. Adams. People have said, hey, I'm working at home. Hey, I'm not really going out. I don't feel like I'm at risk. It's just my husband and me at home or whatever. Why should I bother to get tested? What is the plan for this testing? I'd love your thoughts, Dr. Adams, on that.
And it's a great question. And I hope all of your listeners know that New Hampshire's been doing all the right things, and our prevalence is very low. There's very little community transmission, only a few counties in the southern part of the state that have higher case rates. But for the most part, statewide, and even in our neighbor Vermont too, really great success and great data to report. In the early days where testing was very limited, there were very strict criteria. It was very hard to get a test, even if you think that you did have an indication. But that, as testing materials and testing centers have been stood up around the state, now testing should be available for everybody certainly for everybody who needs it. And there are criteria that you should be following. Anyone with symptoms that are suggestive of COVID absolutely should get tested. Anybody who's a known contact of someone who's been diagnosed with COVID should get tested. And then you start moving down into, other categories where the risk is less. Many of us have been, holed up working from home and not really left our community other than for the solo outdoor exercise, or in instances where we've really been able to keep a good 6-foot social distance and wear a mask, and trips to the supermarket, et cetera. And my sense is, for those people who were, and there was a category of people who were sort of just curious, and my feeling had always been, let's preserve the materials for testing and the PPE that is required for those who are conducting the testing for when we really need it. We don't know what's going to happen with the so-called second wave. So I don't think there's a tremendous need. If people really have been keeping limiting their contacts. It's not even really about staying indoors. It's about limiting your external contacts in a state like New Hampshire, where there's very little community transmission. I don't think that those individuals should be rushing to get tested.
Oh, that's interesting, Dr. Adams, because you mentioned at the beginning of our show that 40% of people with COVID-19 infection are asymptomatic. So is that an argument for getting tested, even if you feel fine and you haven't been going out very much?
So in order to be infected, though, you have to have some contact.
Sure.
So again, I think if you've really been pretty much staying at home, had minimal contact in the community, your risk is quite low. But yes, there are people who maybe are traveling to, elsewhere in New England, or having to travel outside. They come back, they're not symptomatic, but then you could think, okay, I've traveled. Is it worth it for me to get tested? I'm not feeling symptoms. I'm going to quarantine for 14 days if I've been to one of the state, you're following the New Hampshire Health Department's travel guidance. But would it be worth it for me to get tested? But you do have to have contact with someone who has had the disease, symptomatic or not. So I just feel like in our state, where Again, very little community transmission until we're at a state where we start seeing more community transmission. Then I think we can still use sort of a risk stratification approach to testing.
Well, while folks are filling out that poll, and I hope that you are, we are going to take a quick break. So refill your drink, grab a snack, or just sit tight, and we'll be right back. Welcome back to The Exchange, live from home. I'm Laura Kanoy. Today we're talking about how we assess risk and make decisions during a pandemic and how difficult it can be. With us are Dr. Lisa Adams, Associate Dean for Global Health at Dartmouth College and Director of Dartmouth's Center for Global Health Equity, and David Ropeek, a retired Harvard instructor and author of How Risky Is It Really? Why Our Fears Don't Always Match the Facts. Now, we put out a poll earlier for our listeners asking them about this, and I'm going to read you the results. We asked our live audience, what is the biggest factor you consider when deciding whether to change your behavior? So here we go. 4% of the audience said my own personal research and interpretation of the science. 91% of the audience said recommendations from health officials, and 4% of the audience said recommendations from my doctor. So thanks, everybody, for filling out that poll. You can continue to submit your questions on the Q&A. We'd like to know just how you are making these decisions and what's been the hardest part for you about deciding what's risky and what isn't for your family or friends. Before we get back to some audience questions, David, I wanted to ask you about some of the rankings of risk that I have seen, and I'm sure you've seen these too. When the summer started and people started, as you said, getting tired of being cooped up, a couple medical groups and medical writers, I saw a couple of these, put out lists of here are your top 20 summer activities and how risky they are. And they put, playing tennis and camping were very low. And basketball, I think, was sort of moderate risk. Going to the beach, backyard barbecue, all moderate. Going to a movie theater, concert, sporting event, high risk. How do you view these rankings, David? Are they worth the paper they're written on or not?
They're helpful. But the idea that the facts alone will inform the right choice is naive. So the people who are working on informing the public are doing a great service. As 91% of your survey listeners said, those health officials are where people are turning, right? Hopefully they're turning to ones that are reputable. Please ask whether they're trustworthy rather than that just you like them, because there are a lot of people who say they're experts, but they go to Google University, right? So the numbers are helpful, but the numbers, even if you perfectly understand them, and we all have problems understanding numbers in the first place, a problem called innumeracy, much studied. There are people at Dartmouth, at Dr. Adams' school, who are helping people understand the numbers about risk. Even if you understand them perfectly, a person like Mary, who looks at her general sense of numbers about whether I'm at risk or not, and has a general statistical sense of whether she's been exposed or not, wondering about testing, is going to use her feelings to decide how those numbers feel, right? So the numbers are of limited, they're valuable, but they're not going to shape our final choices. That's our feelings that are going to do that.
That's interesting. And I wonder too, David, what might be missing from those numbers? What assumptions are baked into those numbers? For example, they put swimming in a pool as a moderate risk, but is the pool crowded? Is the pool half empty? Going to the movie theater, are you the only one sitting in the theater, or are there 50 other people in there. It seems like there's some assumptions baked into those rankings.
So epidemiologists and health scientists have the problem of studying things on a population level. And Mary asks a question on a personal level. And that's how we see all the information is on the personal level. But you can't study and report on 330 million people. So you have to generalize. The problem with risk communication, which is what I really used to teach at Harvard, is it doesn't say, and a lot of these charts to which you were referring, Laura, was one of them, don't say this. Remember, this is for the general population and your risk will vary. And those risk communication efforts, like those charts that you were talking about, have to say that for two reasons. First of all, so that people then look up information that's relevant to them, right? Because that's really what matters to them. And second of all, it says that we people who do the charts know our limitations. We're being humble. And what that humility does, interestingly, lots of science on this, is it builds trust in the chart. Wow, those people are being honest and respectful of me, maybe not being perfectly matching up their chart, and they're admitting it. They're not saying like they know everything. And that trust building means that people will use the information in the chart more. So
it becomes a cycle almost, a cycle of certainty.
Well, not a certainty, but so like if you see a chart with a bunch of numbers, the first thing I would suggest is who put the chart together.
Right.
Check that out. Think about, whether that's some fly-by-night dude or somebody from Dartmouth or something like that, right? So that's an obvious one. Look at whether the information is clear or talking over your head, right? Lots of scientists like to talk to themselves, especially about numbers. They use percentages. We don't understand percentages for boo. They don't use raw numbers. There are lots of things the charts and lots of other things can do to instill trust. The goal of risk communication, let me back up. Risk communication in a situation like this is a risk management tool to manage public behavior. And as Dr. Adams said earlier, what we're trying to manage here to manage this pandemic more than anything else is how people behave. Public behavior is the key to managing this pandemic. It's not more tests, it's whether we take them. It's not more masks, it's whether we wear them. It's what we do, okay? So risk behavior is shaped significantly by how people feel about the risk, which is significantly manifested by risk communication. There have been governors and mayors and the president who've done it better and worse, and that's going to shape behavior a lot. And so these charts and everything else that we do can help build trust or not. And what happens is when we trust the source of the information will have more weight. And the risk communicator will have more success managing people's behavior. Wow. Trust matters more than just the clarity of the facts.
Lots of questions coming in from our live virtual audience. This is great, and I want to share a couple of them with you. Susan asks, and this is a very big question. We did a whole show on this just yesterday. Susan asks, what are the risks, in your opinion, of reopening K through 12 schools? And Dr. Adams, I apologize. I'm going to throw that to you. As I said, we did a whole program on it, but I would love just to hear you enumerate some of the risks that you see in opening up the schools.
Sure. So let me say that question really needs, in my opinion, really needs to be broken down. Everybody's asking it. Everybody with school-age children, where they're concerned about what it might mean for the community if they do reopen schools, and it really is so dependent on what school, what community you're talking about, where that school is, what's the prevalence in that setting, what are the measures that school district can put in place. Again. Most New Hampshire communities, low risk, so seems like opening schools would make sense. But are there still other actions that could be taken? Does it make sense to do some, make sure that classrooms are set up so that there can be distancing? Masks are hard in younger children, but certainly older school-age kids should be able to follow mask guidance. Thinking about whether there should be shifts in schools that tend to be more overcrowded. Should there be a morning class and an afternoon class to try to, again, allow for some of that social distance? I think there's a lot that can be done in the K-12 school reopening challenges, but I do feel that it's with good state public health guidance, each community has to think about what they need to do to keep the kids and the parents and the teachers in that school district safe. Opening a school in Houston right now is very different than opening a school in Hanover, New Hampshire. And so I feel like you really need to do almost a more community level risk assessment to be able to answer that.
Well, let's take another question from our virtual audience. And Sherry writes, any advice on how to deal with coworkers who are not being as careful about wearing masks and social distancing, putting higher risk coworkers at risk? Wow. Sherry, thank you so much for writing. David, this gets into what you were just talking about a few minutes ago, risk communication. And it sounds like Sherry's having a hard time communicating her risk concerns to her coworkers. And it sounds like there may be some issues at the workplace there too. But how would you sort of untangle this one, David? It's tricky.
Gosh, super hard, right?
Yeah.
Depends on how much you want to have your coworkers like you tomorrow, Mary.
Boy,
Susan,
it's tough.
Yeah, right. The broad picture, let me start with the broad picture and then get to Susan's specifics, because the broad picture helps. So we're at a time of a changing social morality. This disease has really shifted what's right and wrong. We never had to worry about masks, and we very rarely in our recent history have had to really worry about we're all in it together, as we are, right? This, what's called social altruism, kicks in when we're all afraid of the same thing at the same time. I'll do stuff that protects others because that means they're doing the same thing and that will protect me. So that's your workplace question, Susan, and that's a new morality of a social altruism. We're going to sacrifice some of our comfort, and some of our freedom and all of that stuff about masks in the name of the greater common good. But some people are more willing to do that than others. So that's the big picture that's going on. And Susan, when it really comes down to the personal way that you deal with people. So my recommendation for how I communicate risk to friends who have a different view than me is I try to take their standpoint into account and show respect for it first. So tell me why you're not wearing a mask, because you've heard that we're all in this together and stuff, and why are you special or something like that. Try and say it. Don't say that. Try and say it in a non-offensive way. Don't set up defensive mechanisms, right? Don't set it up as a political thing and now you identify with your political tribe, whatever. But try to show respect for their feelings first. That's trust building. That's what I was alluding to earlier. And that will allow the conversation to go better. And that's about all I can offer, is the conversation will go better and you're more likely to come to a positive outcome that way, by showing respect for their feelings first, as opposed to yeah, but, and you're right and they're wrong.
Yeah. All right. Well, it's a great question. I'm glad she wrote in, and good luck to you in your workplace. Suzanne wrote, I remember a talk on risk communication. This is what we've been talking with you about, David, and coming away with, quote, people won't care what you know until they know that you care. So it's kind of what you've been saying, David. People won't care what you say until they know that you care about them, and then they'll trust you some more.
Suzanne probably heard a talk by Vince Cavello, who is was a very prominent risk communication consultant. The point is that risk is a matter of feelings. And if you show that you respect the other person's feelings, any information you then offer to try to persuade them to your point of view will have more trust and effect than if you call them a mask hole. Right?
It's hard
That's
to
gonna go worse.
do. I'm sure everybody listening is thinking, yes, respect, yes, caring, yes, listen and try and learn. But when you're faced with a pandemic that could be deadly, it's hard to just listen with concern, David.
Yes, this is not easy, and I don't do it well either. And listen to me on the radio saying people should do it, and I have trouble with it too, right? I get really annoyed, especially when it's a selfishness that puts me directly at risk, like the tailgater on the highway. I mean, it's the same sort of thing, right? So the thing that I offer to people to encourage them is, if you want the outcome to go your way, be as selfish in your thinking about your interaction as you possibly can be. I want this jerk to put on a mask. The more I treat him like a jerk, the less I'm going to win. Put it in win-lose. win-lose. And then, and then you can even smugly inside your head say, I'm being cooler than he would normally be, and get off on the smugness if you want. But put it in the win-lose, you're trying to get to your goal. And you're more likely to do that by not setting off their defensive buttons. But hard to do, absolutely. You're right, Laura.
Well, all right. At this point, we have to take another quick 30-second break. So again, stand up, stretch, refill your drink, or just sit tight. We will be right back. Welcome back to The Exchange live from home. I'm Laura Kanoy. We're talking about decision-making during a pandemic, assessing what the risks are and how complicated making those assessments can be. With us are Dr. Lisa Adams, Associate Dean for Global Health at Dartmouth College and Director of Dartmouth's Center for Global Health Equity. Also, David Ropeek, a retired Harvard instructor and author of How Risky Is It Really? Why Our Fears Don't Always Match the Facts. So we have a live virtual audience, and you've been submitting questions on the Q&A, and that is great. Tell us what the hardest decisions are that you've had to make in this new normal. And we talked earlier about how decisions that used to seem so easy, should I make that extra trip to the hardware store or not? Should I go over to see so-and-so at her house or not? Now those may seem a lot harder. So tell us what have been some of the hardest decisions for you to make in this new situation we're all in, and how you came to those decisions, how you assessed the risk, so to speak. That's what we're talking about, and we'd love to hear from you. A couple more questions have come in from our audience. Here's one from Sean, who says, medical conferences have been made virtual, including board exams. Even the annual Academy of Pediatrics has made its annual conference virtual. How is it we feel comfortable sending kids back to school? Sean, thank you for writing in. And Dr. Adams, this does get to what we talked about earlier, the different categories and what we know about how this virus does affect different categories of people. And both you and David have said people shouldn't just put themselves in that safe category and say, okay, I'm good to go now. On the other hand, there are differences between children and adults. So go ahead, Dr. Adams.
Sure. So again, by and large, children have done very well, and we even thought that they were escaping this pandemic completely. But that's not completely true, right? And we do know that there is this pediatric immune state, right? The multi-system inflammatory syndrome that has affected hundreds of children, at least just in even New York City, where it's been well documented. And I know from colleagues in Houston that they're seeing cases as well now, as their case numbers peak. So, yeah, so it can affect children and have very serious consequences. But yes, by and large, young children are, on the whole, do very well. So why would we put children into schools and at risk? Well, schools do a whole lot more for children than just take them out of their parents' house for 6 or 8 hours a day. The concerns certainly about the socialization and social growth that happens with children. So education, of course. Lots of children who haven't been getting special services since the springtime, since March when schools closed. Concerns about children who are at risk not being able to be under sort of a watchful eye, and we know that that there have been concerns about childhood neglect and abuse that have gone down because some of those reports that would normally come from teachers and other aides at schools. There's, again, we're talking about evaluating risks here. And so are we willing to say, gee, to have some of the benefits that a school provides, can we do it can we reopen those schools in a way that really mitigates the risk of COVID-19 transmission in the community, have sort of be on first alert for if we need to, unfortunately, shut down schools again. We could do that very, very swiftly, but to balance it out with the benefits that providing school meals too. I mean, school lunches, and sometimes that's the place where kids really count on getting at least 2 meals a day. So you have to, again, I know that a lot of school districts are trying to sort of balance out risks of COVID in the community versus all the benefits that the school system provides.
Yeah, that's the thing that's so tough, Dr. Adams, because, and we've done so many shows on this, what children are lacking these days. I had one prominent pediatrician here in New Hampshire say, literally, I'm quoting, "We can't keep doing this to kids. We can't keep isolating them." He told me he has hospitalized more young people for suicidal ideation this year than ever before. And so that's why he said, we can't keep doing this to kids. And yet there is this disease out there. And even if children don't get it, they can transmit it to adults at home. So I just wonder, as someone who works in, global health, how your average person like me is supposed to figure this out.
Yeah. And again, this is where we are looking to our trusted, as David said, authorities, public health authorities working together, health departments together with departments of education to try to help figure out what is the best way forward. And again, I really do feel like we have to be taking the local context into account in making that balance. So I feel like fortunately we'll have brilliant minds at it, people who who well understand the public health concerns and risks and the epidemiology of the state of the community. We're looking at together with the educational and social needs of that school age community. No easy answers here. I think that's the take home, and being ready and prepared to have to, redirect. We've all seen how we had to do that, and at a Dartmouth College, where I work too, having to, on a dime sort of pivot and switch to online classes over a 2 to 3 week period. We've had to do this many times throughout this pandemic. And so keeping that ability to be able to pivot where needed is going to be an important part. But again, no easy answers here. And we are weighing risks and benefits.
Here's another question that came in from Lacey, who says, I have seen reports from the New York Times indicating New Hampshire is one of the 5 states with the worst availability for testing. However, New Hampshire sources reassure us that everything is under control. Lacey says, as we know, quick available testing will be necessary to follow opening up trends, especially in schools. So what is the truth? Wow. And Lacey, thank you for writing. And I think we're going to have to take another look at the testing picture again on another show, because this is clearly an enormous issue. But it does get to, David, how we assess risk, given that we don't have a lot of testing here in New Hampshire. It's available, but not huge numbers of people are taking advantage of it.
So Lacey asks a brilliant question, which gets to which source of information do we trust? So she mentioned the New York Times versus New Hampshire officials. So ask yourself this, Lacey. Who has some motivation to spin that information one way or another? I'm not taking sides, but as a reporter, I used to be a TV reporter, I would ask myself, who has an agenda behind saying things the way they do? Right? That's a kind of a no-brainer thing to ask yourself. So I don't know what the politics are in New Hampshire, and that's none of my business. But you do. You live there. And you can ask yourself, are New Hampshire officials giving me really trustworthy information? Maybe you feel they are, maybe they aren't. Is the New York Times? And the question there is, whose side are they on? The trust question really boils down instinctively. We have brain cells for this, really, by looking at people's face and listening to their voice and their body language. Is that person on my side or not? because when we were evolving, if they were on my side and the lion attacked, we had 2 people to fight the lion instead of 1. So that's really deeply built into our risk perception, right? So ask yourself this: whose side is that source of information more likely to be on, theirs or mine? And that's a really good way of then weighting the information about the test. You asked a question about test. I'm talking about trust. But who are you more likely to believe? And then the third point is, and as a reporter, I did this all the time, get another source. Don't just let your lazy
Get a
brain
second
go, I'm
opinion
gone.
or a third opinion, just like when we seek medical
stop.
advice. Yeah.
Yeah, you asked a great question at the beginning of the show, Laura, that a lot of people are wondering, how do we make decisions about this? And if I can address that for just a moment. We make them really lousy if we make them without thinking carefully. As I've said throughout this whole conversation, we make them more with our feelings, and that's prone to making mistakes if we jump to the conclusion. That's the way our system is designed. Jump to conclusions. Because if it's a snake or something really immediate, we got to do it right away. This is too complicated for that. This is not snake time. This is think it through time. Fight, and this is hard to do, fight the instinct to just make up your mind real quick. Stop. Stop for 3 seconds. Stop for a minute. Ask yourself questions about, is the source trustworthy? Do I know enough information? Am I coming at the question of should my kids go back to school or not as a community leader or just a parent? Right? Because the community leader has to take all the stuff in that Dr. Adams was talking about versus, I think it was Sean was talking about kids going back to school. Maybe Sean's a parent. So stop. That's the key. Stopping allows your reasoning brain more of a voice. It literally takes work. You don't want to do it. You have to look stuff up. You have to think, but it will lead to healthier choices. Stop and then get more information, especially from sources you can trust based on, are they likely to be spinning things to their own agenda or to be fair with the facts?
Here's a question specifically about New Hampshire that I want to ask both of you. And David, I'll ask you first. It's come up a couple times this hour that New Hampshire, at this point, has low rates of coronavirus infection, although Lacey questions those numbers because not that many people are getting tested. But in general, our state and northern New England overall, so Vermont and Maine, have not been as ravaged by this virus as many other states, especially in the South and West, as we're seeing now. To you first, David, how might that message, which is a message that, of course, as a New Hampshire person, I want to hear, but how might that message change people's perceptions here in the Granite State about their risk and how they should behave based on that perception of risk?
It's a dangerous message to rely on. And all you have to do is look at all the states where there were no infections at first and now are going on fire. They all said the same thing. We didn't have many. And they didn't. They were behind the curve of Boston and New York and places that probably people from China flew into first and were off to the races. Look at all the curves in the newspaper or anywhere you want to. The other states are catching up to the early states. This virus doesn't care about anything except an immune system that has no defenses. And New Hampshire has plenty of those. And eventually people in New Hampshire go to the store. And eventually people in New Hampshire interact with each other. Less in the north, more in the south. That's why we're seeing what we're seeing now. But every lesson from this pandemic so far, not just in the US, but around the world has said, the places that say we don't have many, we don't have to worry about it, get bitten in the butt at the end for having said that. This virus will spread wherever vulnerable victims interact. And New Hampshire will have more cases, I'm sorry to say. And the behavior of New Hampshire residents can reduce that now by taking that threat more seriously.
It's tough, though, isn't it, David? Because in one sense, you think, gosh, I've been locked up for 4 months and gosh, I'd really like to get out and do this. And for my mental and physical health, I want to do this. Or, young people, kids, they developmentally, they need to be together. They need to see their friends. So it's tough.
It's super tough. And you bring up something else that's really important. I know our time is semi-limited, but I wanted to make this point. There are profound secondary health effects from what we're going through to protect ourselves from the primary threat of the disease. I think it's relatively safe to say that in 10 years, 5 years, 2 years, whenever the kind of spreading has settled down and the hindsight 2020 stuff is done, that the cumulative effect on the world's society and even our health from the lockdown may exceed the actual health count from the disease itself. Let me be specific in two ways. You mentioned kids, so that's, the whole psychology of kids. There's more domestic abuse cases being reported because people cooped up at home. That's tiny. Let me get real specific. When we're cooped up and we don't have A, social contact, which the social human animal needs, and B, control over our lives, we are under stress.
Anxiety,
biological
depression,
stress.
All those
that
things.
has a bunch of fancy psychological names, but now let me get biological about all that. All those things trigger a fight or flight response in our animal brain. And it's same as if it was a snake. All right. And when those systems get turned up or down, the ones we turn up to fight the lion and we turn down the ones we don't need to fight the lion, and stay that way for more than a couple of weeks, it contributes to, listen to this list, increased risk of cardiovascular disease because you have constantly higher blood pressure, increased risk of all sorts of immune disease infections because your immune system is suppressed, increased risk of clinical depression, which hospitalizes 18 million Americans a year, increased risk of adult onset diabetes, the number 4 cause of death in the United States, if not 3, I forget exactly. There are profound secondary risks from the tension we're all undergoing. And so treating that in how we behave is a super important additional message. Keeping risk in perspective is the simple way to say it, but balancing the risks of those things versus the risks of the disease itself is super important and embedded in your question.
Wow. So now I'm feeling worse, David.
Yeah,
I mean,
sorry, but that's
and
an
I
important
appreciate you
warning,
being
right?
honest, but there's
Sorry.
the disease, there's the fear around that, but you're saying the fear and stress that we're feeling about this disease and whether we're going to get it and how long it's going to go on is also going to make us sick because, as we know, those high cortisol levels and stress and anxiety will lead to diseases. Go ahead.
Let me be very concrete. There's research that in New York City, the closer you were to 911 and not hurt by 911, the higher your rate of cardiovascular disease in the 3 and 6 and 9 and 10 and 12 months and 5 years out later after the disease. After 911, people were afraid to fly, so they drove. And the death toll on the roads went up by 1,500. That's half of what were killed that day in traffic accidents because people were afraid to travel in a safer way to go. Risk in perspective, which is what I wrote my book and why I talk with such enthusiasm about this, is super important to our health. And being aware of the secondary risks can help keep risk in perspective.
What do you think, Dr. Adams? Again, the news that most people would perceive as good, New Hampshire's numbers look pretty good, especially compared to the rest of the country. Does that encourage people to take risks that they perhaps should not?
Unfortunately, it does. And we talk about this in public health all the time, that success in public health breeds complacency. I always say public health is plagued by the fact that when your interventions are successful, nothing happens. There's no cases, there's no deaths. That's all very good, but it starts to make people wonder, do I really need to, change my behavior? Now, was it really all worth it? So part of, I feel like, what my job and with my public health hat on and physician hat on is to remind people that we're in great shape now in New Hampshire and in neighboring Vermont and Maine, as you pointed out, because we have been doing the right thing for so long. We've been careful. We've stayed home. We've washed our hands. We've physically distanced, and we're wearing masks when we go out, and it has paid off. But now is not the time to let our guard down. And I completely agree with what David's saying, though, is that we have to simultaneously be thinking about how we are going to cope with pacing ourselves for the long haul. And whether there's going to be sort of a staccato approach to this, we're going to reopen, then we're going to realize we have to close down and shut down. We're going to have some reopening, and then we're going to see cases go up, and we have to close down or shut down. It may be that staccato approach, which is what many epidemiologists are predicting, or just maybe sort of a long, constant haul. And we have to figure out at the same time how to deal with that and prepare ourselves for what that looks like. knowing that a vaccine is months, if not a year, or possibly more away.
One last question for both of you, and there's so much more to talk about. But David, in terms of how people judge risk, again, your area of expertise, and it's so interesting. What's been most interesting to you, David, in observing all this and living through it yourself?
I've been inspired. I think the first thing that comes to my mind is I've been inspired by the social altruism that the world is showing about this. So I can't think of a time in human history when everybody on the planet was afraid of the same thing at the same time. Everybody on the planet is now kind of aware of COVID and afraid of it, kind of, right? Even in World War, right? People in Kansas weren't afraid of bombs falling on them in Kansas, right? In the modern era, with information being what it is and our globalized society being what it is, we're in an unprecedented time. And what's showing up is overwhelmingly, despite all the people that one of your callers asked about not wearing masks, they get a lot of attention. Overwhelmingly, the surveys show that people are doing the right thing in the name of the common good. That's the inspiration. That we are, as animals, in the name of our own safety, responding in a way that will put ourselves at some discomfort, sacrifice resources, the way the economists like to put it, in the name of the greater common good, so that we are also protected. This goes for everything from artists performing free concerts online to people wearing masks to my favorite story is the Yemeni camel races this year were called off because the camel herders thought that they couldn't maintain social distancing. Like, I'm in the same boat with those guys. That's a cool world to be in. Our world has lots of divisions. Tons of divisions, normal, and they're exacerbated now for lots of reasons globally and locally. And to see that togetherness is super and really needs to be, we shouldn't lose sight of that we have that in us.
Dr. Adams, it's been said a lot of times this hour and so many times over the past 4 or 5 months that the virus is new. Everybody's been learning about it. You gave that analogy, flying the airplane at the same time that you're building the airplane. What's been the most important evolution, Dr. Adams, in terms of our understanding of this over the past 4 months?
Well, I really like where David was going with all of this, too, in terms of thinking about how, in many times, it is our collective response that is what has been so exciting. There's lots of very interesting science behind this pandemic, but to me, it's really been the human and social, that collective response. And just to even kind of build on what he was saying, one of the things that I find most uplifting is that while we have talked about success not being guaranteed in settings such as New Hampshire, but neither are poor outcomes inevitable. So some of my colleagues through the Center for Global Health Equity, which you mentioned that I direct, have done some work looking at vulnerable communities throughout New Hampshire and Vermont, some of the most rural, most at-risk communities, and found that healthcare organizations really partnered in some new and novel ways to prepare their rural critical access hospitals to care for those who were ill. They found that there were different social service organizations that stepped up to identify groups who were especially at risk for contracting the virus, such as some groups helped identify those in need of housing and found space for them at local motels. Just some really creative solutions to, in that case, addressing homelessness. The school buses that used their bus routes to get food to families. Again, really innovative ways that I think extended this sort of necessary social safety net that has helped those who otherwise might have been at greatest risk really get through. And I think it does help remind us that there's ways in which we are bound together at this time, and ways in which so many examples of how if we come together, we can get through this together.
That was Dr. Lisa Adams, Associate Dean for Global Health at Dartmouth and Director of Dartmouth's Center for Global Health Equity. Also, David Ropeek, a retired Harvard instructor and author of How Risky Is It Really? Why Our Fears Don't Always Match the Facts. And now, live audience, stay tuned. We're going to take a quick break to bring our producer, Christina Phillips, into the conversation for our special after show after the exchange. We're going to answer some questions that maybe we didn't get to. And if you have any questions for me or Christina or the panelists about this event or how Christina and I are doing our jobs during the pandemic, you can post those now in the Q&A. I'm going to give some quick thank yous, though, before we do that. Our team here at The Exchange Live from Home includes our engineer, Dan Colgan, producer Christina Phillips, Patricia McLaughlin is our director of marketing and communications, and our engineering team is RJ Perkins and Randy Woods. Tim Brady is in charge of corporate support, and the wonderful graphics and design you saw tonight are by Sarah Plord. This is The Exchange Live from Home. I'm Laura Kanoy. And we're back. Joining us is producer Christina Phillips. And to start, let's answer a question that we didn't get to in the hour. And again, our virtual audience, if you have questions for me or Christina that we didn't get to, or our guests, feel free to put them in the Q&A now. So go ahead and do that. If you have any questions for the guests or how Christina put this whole thing together, or again, what's it been like for us to produce this live radio show day in and day out in a pandemic, working remotely, and so forth. I did have a question from Sarah that came in, and Dr. Adams, I might throw it to you. I didn't have time to get to it during the regular show. So Sarah, apologies for that. Sarah says, according to DHHS data, the number of cases in New Hampshire has gone up 30% in the past 6 weeks since reopening. The cases are rising fastest among children under 9. What else could be done to reverse this trend? Now, I can't independently verify that information. So, Sarah, I'm going to have to go with what you said. But Dr. Adams, what can you tell us about rising cases among children?
Yeah. So I do know, I was hearing some of those and looking at some of those data as well. So do you know that there has been this uptick? I don't know if I appreciated how many days it had persisted. Again, I think we have to look at where cases are occurring, and that's one of the nice things that the health department website, the DHHS website has, is down to the county level, sometimes even down to the town level for certain data. And I have colleagues there who are really looking at it at that level to try to figure out where there are peaks. I actually thought I had heard about cases in long-term care facilities peaking, not in children. So I'd have to go back and look at those data. And we do know, of course, that residents of long-term care facilities are at great risk because of their age and comorbid conditions and their congregate living settings. So it's unfortunate, but not a surprise that we might see peaks in those settings. So I'd have to go back and look at what we think is happening in children. But let's face it too, it's tourist season, right? And we've wanted to reopen the economy. And again, another balance of risk and benefit here of trying to make some decisions to preserve and reactivate the economy, finding ways to safely welcome tourists back. But we know that that's going to carry some risk with it.
And people want to get outside and get that important fresh air and exercise. So it's that balance that you talked about earlier. Yeah.
And it's not so much the solo exercise that people might be doing or, with either household members or with others that they can keep a physical distance from. But I do, have to think about as restaurants start to reopen and get busier. And I know they're doing a lot of outdoor dining, but you think about the cleaning practices that have to happen, movie theaters reopening. So everything increases our risks just a little bit. And so we have to be aware that might happen, and we have to be just so attentive to it and be able to respond very quickly when we see rises in cases.
So here's another question that Jim just wrote in, and thank you, Jim. He says, someone in the national media surveyed epidemiologists about their willingness to do certain things, fly, shop, go to the dentist, etc. As a layperson, would I be smart to simply base my conduct on what epidemiologists are willing to do? And Jim, I think it was the Washington Post, because I saw that too, and I read every line. And this is what, you've been talking about, David, is I read that same thing that Jim read. And in a lot of instances, I thought, okay, that makes sense. But there were a couple where I thought, no, I'm going to do that. So I just wonder how people like Jim should read those lists. And we talked about the rankings earlier by epidemiologists. Would you shop? Would you go visit your adult children? Questions like that. Would you swim in a public pool and so forth?
So Jim asked a wonderful question, because the way he worded it, if I recall you reading it, is, would I be smart too?
Yes, right. Yep, that's what he says.
Right? And the answer is yes, Jim, you would be smart to look to experts for suggestions as about what they would do. But in the end, you see you in the mirror. And if your daughter's getting married or your grandmother's on her deathbed, the Washington Post, it didn't have you in it. I have a good friend who is super risk averse. I can't get her to come over to my house. We have a nice outdoor screen porch, we have a pool we could hang out in, no masks and stuff. Oh my God, she just won't come out of her basement. And I love her and I totally respect it. I have a different risk perception than her, but she said she has relatives out in the West, two of whom are tending to the Navajo reservation serious outbreak, which if it were a nation would exceed most of the nations on the earth.
Wow.
Because they don't have clean water and they have a lot of other comorbidities and stuff. And her son said, don't come and visit me and your grandchild, like a 2-year-old grandchild, unless you need to. There's your word, Jim. Do you need to? Not just do you want to. That counts too. You want to go shoot some hoops. That's a want to. Ask yourself a do you need to question is a way of clarifying what you're trying to think through. And it prioritizes the risks and the benefits. And then in the end, good luck to you. I hope we're talking next year.
Yeah. Well, thank you for writing in, Jim. And by the way, if listeners are curious, as we talk about risks and so forth, Christina, our wonderful producer who put this event together, she's wearing a mask because she is in a shared studio space with Dan Colgan, our equally wonderful engineer. I am not wearing a mask because I am in a large room by myself, although I did wear one when I came in. So I just want to let everybody know about that. Christina, I want to ask you a question too, if I could. You've been working on the show remotely from home, and then you put this whole show together, live virtual event on an online platform. Lots of people can watch. What did it take to put all this together? I'm the lucky one. I just worked on the script and showed up and so forth. But you had a lot of pieces to put together.
Yeah, well, I will say that I need to take these off. I will say that I am not very good at spatial awareness. So there was a lot of me sitting there in the studio with RJ, our engineer, who basically got all of this video and all of the audio connected, and he sort of performed miracles. But there was a lot of me sitting there going, so if you do this and I'll do that, and then you do that and I'll do that. And so it was taking my normal job of a producer and magnifying it by 10 extra layers. But I think what's been really exciting about this is that we've gotten to layer a bunch of new things onto what we already do as a show. So I'm able to see and respond to people in real time when they're chatting in the Zoom. And also we were thinking about ways that we could make this more interesting as a Zoom conversation as opposed to just listening. We wanted to feel like it is an actual conversation. And definitely for the future shows that we're going to do, we're really thinking about, what makes people want to join a webinar and participate in a webinar as opposed to just hearing something on the radio. So it's been a lot of fun. It's like producer plus, like turning up all of the producer skills a little bit higher.
Right. Well, everybody's had to get creative and everybody's learned new skills, definitely during this pandemic. I certainly have. In terms of that daily show, Christina, that you and I work on together, how would you say your approach toward producing it, towards presenting it has changed?
Since the pandemic, I would say that we have thought a lot more about the fact that because there's so many public spaces that were closed for a while, people who maybe would have been able to access the show either because they were in their cars or they were going to work or they were able to go to a public space to use the intranet, that might not be happening. And so we really wanted to think about what sort of service can we provide people if they turn on their radio that they can't get elsewhere because they are isolated. So a lot of what we were thinking about as far as shows was how do we transmit all of this basic information that we're sort of being onslaughted with to our audience in a way that's concise and clear and in a way that allows them to ask questions and respond to us in real time. So we knew exactly what people needed. So I feel like we have tightened that gap between listener and show a little bit more because we recognize that a lot of people are more isolated now and maybe are not sure where to turn, and they may be relying on us a bit more in this time than they would when maybe there isn't a pandemic. So that's what we've been thinking about.
Yeah, and there's so much information to wade through. It's been overwhelming, I have to say. Every day there's just so much to learn and so much to know, and it has been changing a lot. Christina, I have another question for you, and then I want to ask our guests a similar question. But first, Christina, please. What topics do you find are really resonating with our listeners right now?
Ooh, I think there's been a little bit of fatigue. So I think that the topics that resonate are the ones that are getting away from the pandemic in some ways. I think people love to talk about things that maybe are giving them a little bit of a break. But at the same time, I think a lot of people are just thinking about the various ways that our lives have changed for the long term. So any shows where we're talking about, what the future might look like and how this has changed the way you see your relationships. It's changed your job, your financial outlook. Those seem to be the things that people are tapping into. And then, of course, anytime we do something fun, like we had a great movie show a couple weeks ago produced by Jane, who's one of our producers, I think people were like, yes, let's talk about movies for a little bit because we all
fun.
just want a break and want to talk about movies. So yeah, there's a lot of anxiety about the future. I know I feel it, and I think a lot of our listeners feel it too.
Well, and that was a little preview you gave us there, Christina, right, of our next virtual events. We're going to be covering some of those topics that you just mentioned. For example, how the pandemic has affected, sort of the economy writ large, but more specifically, people's own economic situations. So not macro, micro, right? That's one of the topics that we'll be covering.
Yeah, definitely. How has your life changed? How has your bank account changed? Has it changed your life plans?
Yeah. Well, and a similar question to you, David, actually. What do you find people really want to talk about right now? Friends, family, colleagues, under this larger topic of the pandemic, of course. What aspects of this really seem to get people going?
How can we move past the total lockdown into something that approaches a normal life?
Without taking on too much risk, right?
Yeah. And what it boils down to, by the way, in all those conversations is who do we trust? So we've had people over for dinner and, to hang out at the pool, whatever. And I know that those people have been careful. I haven't screened them. I haven't tested them and swabbed their noses. But I find that everybody has on their mind an impatience or a fatigue to try to move ahead with normal gets bandied about, having control of their lives back, doing stuff, going on vacation. This question of do we go back to schools is in the same context. I live in a suburban neighborhood. A lot of parents, a lot of kids on the street are talking about the what next. I think the what next and how do we get to the what next safely is what I hear is on a lot of people's mind. Mine too.
Well, it's interesting. You said, you hear a desire to, quote unquote, get back to normal and do those things that give us pleasure. And it relates to what you said earlier, David, about, you're concerned that people's anxiety about the pandemic will make them unhealthy, even if they never, get coronavirus infection. And so it's tricky because people want to engage with those things that make them feel better to reduce their stress about the virus, but they don't want to get the virus. So we're kind of like chasing our tails here. You know what I'm saying?
There's one thing you're absolutely right. You're absolutely right. And there's one thing that on the topic of how do we deal with all of this, that this show was really about, that I did want to get to. I'm glad you brought it up. It's nothing personal to NHPR, and public radio all over the place has been an awesome, super important source of trusted information for all of us in these days. And kudos to everybody in public radio who's done that. But turn it off. Turn it off.
I think the World Health Organization has told people to limit their media.
Yeah. So there's hard science in this, right? So basically think of your consciousness as a radar screen. So if the radar screen is full of blips about, oh my God, right? What's that going to do to your stress levels, right? So turn off the 24/7, oh my God-a-thon, the sky is falling-a-thon, right? And take the dog for a walk, or read a book, or hang out, or you just take a walk, whatever, be informed, totally be informed, of course, but you don't have to be 24/7, oh my God, informed. Mm-hmm. And that will reduce your stress level right there.
That's a great quote. David, I'm going to use that. The 24/7, oh my God-a-thon.
Yes.
And I feel it. I've been living that myself.
Well, yeah, we all are.
Dr. Adams, last question for you. What about in your world? What aspects of this do you really hear people wanting to dive into? And by the way, I'm wondering if sometimes you're ready to turn it off, and then you talk to friends or family, or you're walking around your neighborhood and people are like, ooh, Dr. Adams, what about this? And you don't want to talk about it.
Yes, well, and I think, one of my other hats that I'm wearing is the COVID Response Task Force co-chair hat for Dartmouth. And so I am in the 24/7 plan-a-thon, prepare-a-thon, as we think about what our fall and beyond is going to look like. And it's true. I think unplugging is so important. It's great to have, friends, people that you can socialize with who are outside of your work life, and who do want to talk about something else that is really important. But I get mostly not so much people. I have had people been driving by as I'm going on a solo walk and pull over the car to talk to me about questions. But I get a lot of emails too, and maybe I have a lot of friends who are plugged in 24/7, because many times the questions I get are, what's the worst case scenario? Like, they sort of want to be prepared for what's the worst thing that could happen this fall as colleges and universities reopen, as schools start back. Like, what should we be prepared for as the worst thing that could happen? I think that's a little bit of a self-protective. It's like, okay, if I consider the worst thing that could happen, everything else is going to be better.
Especially since we never imagined that we would be in this situation, ever.
Never. I recall discussions that I had with friends and colleagues at CDC and health departments who said early on, think about your spring term. We're on quarter system, so we have a spring term being online. And we all thought, what? That would never happen, let alone spring, now summer, and then a hybrid fall term, with most classes being taught online, even with some students coming back into residence. So yes, really never thought we would be here. So I think trying to, it's not a bad thing to think about what is the worst case scenario, because then you can always dial it back from there, and then everything else is easier. So we do get a lot of that.
That is all the time we have, and we could have talked a lot longer. And I want to thank everybody who joined this virtual event, and especially our guests, of course. And everybody, remember, we're going to air the audio from tonight, this Thursday at 9 a.m., so during our regular exchange slot. And you can find information for all of our upcoming virtual events at nhpr.org/exchange. So our next virtual event takes place in 2 weeks, Tuesday, August 4th, with a look at the economic impact of the COVID-19 pandemic and its impact, as Christina just said, on personal finances. This is The Exchange, live from home on NHPR.